Okay, everyone. Chapter 23, we're going to go over drugs for neurologic disorders such as Parkinson's and Alzheimer's disease. So, Parkinsonism, pathophysiology is it's a chronic neurological disorder. Essentially what happens is those dopaminergic neurons, those neurons that secrete and uptake dopamine, degrade. So you may have enough, and effectively what happens is that you just don't have enough dopamine and you get an imbalance of the neurotransmitters.
Parkinson's disease, and in fact, I might take this opportunity right now to try to explain to everyone what Parkinson's disease is. You know, it is a chronic and progressive movement disorder, and of course, given that it's a movement disorder, it does start in your brain, and it starts at the level of the brain cells, particularly in an area called the substantia nigra. This is an area of your brain that is very important in terms of controlling movement and what we call in medicine your motor function. What happens is at the neuron, the level of the cell in your brain, those cells can not only die, but they lose their ability to produce dopamine. Dopamine is absolutely essential, especially when it comes to movement and coordination. And anything that upsets the balance of dopamine at the level of your neurons can create symptoms of Parkinson's. One of the most common things you're going to see with Parkinson's is something that's known as a resting tremor. Maybe the very first sign that you notice in a loved one that's going to make you want to go get them checked out. It's not just resting tremor of the hands, which is very common. It can also be the arms, the legs, even the jaw in some situations. Now, with Parkinson's disease, a lot more can happen. Some patients will suffer from stiff joints, painful joints. But another big thing to look out for is if you notice that your loved one seems to be losing coordination, walking becomes more of a shuffling gait. These are things that you have to look out for. Get it checked out. Some other early warning signs for Parkinson's. You can have fine motor skill difficulties. You can actually get loss of coordination, stiff muscles, tremors, as I mentioned. If you notice these things, you want to get it checked out because there are treatments that can really improve. We're going to talk more in the next segment about those treatments. There is hope, and so that's why diagnosis early. So he, again, didn't.
Okay, so essentially, as I said, you get a degradation of the neurons, and that affects the ability of dopamine secretion, which is vital for that smooth, sort of coordinated movement. What happens when you don't have enough dopamine is that you get that tremor, and essentially what's happened is you have other neurochemicals that are trying to excite the muscles in order to get movement, and you get that tremor, that non-sort of purposeful tremor. So you can get tremors, just like he said, of the neck, rigidity, slow movement, bradykinesia. So obviously anything brady is slow, right? So bradykinesia, kinesia is movement. You'll get postural changes. What those mean is they tend to hunch a little bit. Head sort of is usually looking down. Head and chest are often thrown forward. You get that shuffling walk, a mask-like face or facial expression. And the classic sign is that pill rolling motion of the hands, and that's a very early sign.
Back to the Future was a film that helped define the 1980s and made Michael J. Fox a star. More hit movies followed, as did a string of awards for his TV series like Spin City. Now, though, his future's increasingly defined by Parkinson's disease.
As soon as I wake up, I can't go back to sleep. I mean, it starts going. So I would say that's the toughest part in the morning is to kind of go, well, I'm up whether I like it or not, I'm up now. And the other thing that happens to me in the morning, first thing is I get dystonia, which is kind of cramping, and it can be very extreme.
In a rare interview on ABC, he spoke about the new challenges from something as simple as using a toothbrush.
Sometimes I have to put the brush down on the countertop, hold it flat, and get the brushes on, because if I hold it, I'll miss it. It's a moving target. But anyway, once I get all loaded up, then I just kind of bring it up to my mouth and then just let it go.
Remarkably, he also revealed that ice skating appears to temporarily block his symptoms, but only while he keeps moving. There's no cure for Parkinson's, but Michael J. Fox has been fighting to change that. He's gone from actor to activist, campaigning for politicians backing stem cell research, which might offer hope to Parkinson's sufferers. Millions have seen the powerful TV campaign he made a few years ago.
They say all politics is local, but it's not always the case. What you do in Missouri matters to millions of Americans. Americans like me.
Michael J. Fox returns to ABC.
He devotes much of his life now to raising awareness about Parkinson's, and after many years off the big screen, he says he still watches his old life on the small screen.
And at any given moment, I can flick through the channel and see myself, and for a long time it was just like I stumbled on an infomercial or something and just keep clicking. But now every now and then I will stop and watch it a little bit, and I'll just enjoy it. I'll just enjoy it for what it is and the time it was in my life, and I don't have any. There's no wistfulness in it. There's no longing.
Richard Lister, BBC News, Washington.
Okay, so obvious classic example of what advanced Parkinson's looks like with Michael J. Fox. He's probably one of the best known people who's out there supporting that cause. So the treatment regimen. Well, how do we do this? Well, cholinergics compete with dopamine at the neuron. And so one of the ways that we attempt to increase dopamine utilization within the cells is to block those cholinergic receptors. We can also give medications that convert chemicals to dopamine and in effect then increasing the amount of circulating dopamine within the brain. Dopamine agonists, so they stimulate the dopamine receptors to secrete more dopamine. MAOB inhibitors, which is an enzyme. MAOB is an enzyme that interferes and blocks dopamine. And so if we decrease that enzyme, then there's less of that to interfere with dopamine's ability to be secreted and be taken up. And COMT inhibitors, that's an enzyme that inactivates dopamine. Now, the only problem with all these medication regimens is that they're limiting. We get great results when we first start using it, and then over time they become less and less effective, and that's because the neuron itself degrades and there's nothing there to even receive dopamine. So anticholinergics are common parasympathetic drugs, things like gogetin and artane. They inhibit the release of acetylcholine, which again competes for those dopamine receptors. So what this will do is it decreases those tremors and rigidity. As I said, there are some neurochemicals in there that when there's not enough dopamine, they take up a lot of that. They take up a lot of the receptors, and that's what causes that rigidity or that tremor, the hyperexcitability of the neuron. Some of those nursing intervention anticholinergics, they can decrease blood pressure and increase, but they can also increase your pulse. You need to monitor urine output to check to see if they're retaining urine. Essentially, the bladder won't release the urine. Increase fluid intake, fiber, and exercise to avoid any problems with constipation. Anticholinergics, we use them a lot to dry people up before surgery. So they obviously can cause constipation. A big factor in constipation is just not enough fluid in the bowel. As they're observed for involuntary movements, advise a client to avoid alcohol, cigarettes, caffeine, aspirin to decrease gastric acidity, which can interfere with absorption of the drug. Encourage a client to relieve dry mouth with ice chips, hard candies, or sugarless chewing gum, and suggest the use of sunglasses for photophobia. Dopaminergics. Those are those drugs that help with the help conversion to dopamine. The most common one is Cinemet. So the side effects, it can cause fatigue and insomnia. Dry mouth is common, blurry vision, orthostatic hypotension, so that lowering of the blood pressure with the increased amount of dopamine. They can cause palpitation and dysrhythmias. Again, we're working with some of the involuntary muscle. Urinary retention, nausea and vomiting, and dyskinesia. And that's dyskinesia, psychosis, and severe depression. We tend to get that when there is too much. The body isn't excreting as much as it should because maybe there's some renal insufficiency, or we're giving too much of the drug. So what we want to do with levodopa is it will decrease the effect if that patient is taking anticholinergics. Obviously, anticholinergics also dry out the mouth. We have to watch out. Tricyclic antidepressants compete in the same pathways, so you can get a decreased effect with Cinnamon if they're on those anticholinergics or antidepressants, excuse me. MAO inhibitors, benzodiazepines, vitamin B6, we have to watch out, and that's one of those things we have to ask those patients is what are you taking from a vitamin standpoint. So, dopaminergics continued. We've got carbidopa and levodopa. Some of the when levodopa is used alone, only about 1% of it will reach the brain. 99% converts to dopamine while in the peripheral nervous system. So away from the brain and essentially out in the tissues. By combining carbidopa with levodopa, carbidopa can inhibit the enzyme decarboxylase, in the periphery, thereby allowing more levodopa to reach the brain. Dopamine agonists, those are those dopamine-like drugs. It's also Simitrel, which is also used as an antiviral drug for influenza A. It stimulates dopamine receptors, so that causes increased dopamine secretion, so that you can combat some of these effects of that low dopamine secretion. You can take it alone or in combination with levodopa or an anticholinergic. It's an early treatment for Parkinson's as drug tolerance develops. And as I said before, this is one of those drugs that we give it, we see phenomenal results very early, and then within a couple of years, it really sort of slides and doesn't do any good. So we start out with it, and then eventually we have to move to another drug. Nursing interventions, we need to monitor for that low blood pressure, administer the drug with low-protein foods, avoid vitamin B6, alcohol, or other depressants. Do not abruptly discontinue because you can get a reflex if you suddenly come off these medications, and what I mean is that things get suddenly a lot worse. Warn of harmless brown discoloration to the urine or sweat. That's common with these drugs. Assess for suicidal tendencies, and that goes along with the increased chances and risk for depression associated with these drugs. Assess symptom status for on-off phenomenon, where the symptoms sort of progress and then suddenly are gone and then return, even while on the medication. And then monitor blood cell counts, liver and kidney function. All these drugs are metabolized both through the liver and the kidney. Alzheimer's disease. It's a progressive degenerative disease. Essentially, plaques form that inhibit the ability for the neurons to fire. You get these neurofibrillary tangles, and there's also a cholinergic neurotransmitter abnormality.
Who are you as a person? It is the sum collection of all your experiences your entire life, stored as memories, and then all your life, as you experience new things, you're associating them back on what you've already learned. And that's memory. And based on how you're forming memories and learning, you're behaving a certain way, and that's your personality. Alzheimer's disease robs every bit of that.
Alzheimer's disease is a form of a neurodegenerative disease that causes dementia. Dementia is really just a progressive loss of cognitive function and changes in behavior. Alzheimer's disease is the most common form of dementia.
Apple, table, and penny.
Apple, table, and penny.
So I'm going to ask you those again in a minute, okay? So hold on to them.
The most salient symptom is what we call episodic memory impairment. So that's when people have short-term memory loss.
Do you remember the 3 words that I told you?
No.
We think that you form new memories by making particular connections or synaptic connections, we might say. And we know that there are certain parts of the brain that are very important for forming those memories. And one of them is called the hippocampus.
The hippocampus is located inside the medial temporal lobe of your brain. It works together with a neighboring area called the entorhinal cortex, which processes sensory information to form and consolidate memories. The amygdala, which are 2 almond-shaped areas also in the medial temporal lobes, are responsible for emotional memories. All of these brain structures, like other parts of the brain, contain nerve cells called neurons, which communicate with a network of other neurons through connections called synapses.
So in Alzheimer's disease, the first thing that happens in all cases is that where that sensory information is coming into the entorhinal cortex, and then there's that perforant pathway that goes to the short-term memory, hippocampus. That path gets severed. Not right away, but it gets whittled away and eventually severed. So that when sensory information comes in, okay, and is trying to be stored in the hippocampus, it can't get there.
Okay, so essentially what we're talking about with Alzheimer's disease is really it begins in the early stages. What you'll notice is that there's a short-term memory loss. People, even in sort of a medium to advanced stage, patients will be able to talk in a very detailed manner about past life experiences prior to the onset of the disease. And then after the onset of the disease, they slowly lose that ability to remember. And then eventually, as the disease progresses, where they can't, the memories and those things coming in, or those sensory impulses that are coming into the brain and are never stored in the hippocampus, they can never get there. There's no long-term storage and they're gone, but eventually it gets to a point where even the body fails and they die because of the Alzheimer's disease. So if you're looking at this particular picture, you see a nice normal neuron there. In the A, in A, and then with B, you see these neurofibrillary tangles that essentially screw up the ability for the neuron to work, and then they add in plaques that further sort of degrade the signal in that part of the brain. So characteristics, we'll see a loss of memory, logical thinking, and judgment. There's a time disorientation. There's that, 8 o'clock at night, they're up and they're walking around when they normally would be getting ready for bed. They remember that they'd been up all day during the day, but they're obviously don't have any memory of that. Obvious personality changes. Early on, it tends to be more of the defensive. They sort of understand that something's wrong, but they don't want anyone to know. Maybe they remember a loved one who had Alzheimer's disease, and they can see it happening to themselves, and so they become defensive. But eventually, it progresses sometimes into even violent behavior. Something just completely uncharacteristic to the person's previous response to stimulus. You'll get hyperactivity, tendency to wander, inability to express themselves. They lose the understanding of words. They tend to be paranoid. So what do we use? We use a couple of medicines, and usually we'll put them together. One is Aricept, the other one is Exelon. They allow more acetylcholine in the neuron receptors to increase cognitive functions. It's used in mild to moderate Alzheimer's disease. The only problem with these medications is they are not a fix. They essentially delay some of the onset of symptoms and allow some improvement, maybe slight improvement initially, but they can essentially allow for better functioning for a longer period of time, but usually it's only a year or two. Side effects, they can develop headaches, dizziness, there can be some depression, dehydration, dry mouth because we're dealing with cholinesterase, constipation, blurred vision, insomnia. These sorts of inhibitors will also cause hypertension, but can also cause hypotension. You can get this decreased blood pressure, and especially orthostatic hypotension, where they'll stand up and then suddenly the blood pressure will drop and they will feel faint or dizzy. And because this is all metabolized through the liver, you can get some hepatotoxicity where there's just too much drug in the system and in the liver, causing some liver damage. Some of the things that we need to do, obviously we need to monitor vital signs, particularly when they're up and around, when they're getting out of bed. Maintain very consistent care where one after another, every day is the same, and that will help. The brain's kind of an interesting thing in that you can still learn habit formation outside of the ability to remember short-term memories. So a consistency in care will allow that sort of habit formation within their brains, and they'll get used to particular habit patterns without even realizing that they've done so. Monitor behavioral changes. Obviously we want to be early, really detecting things early, especially if they're a danger to themselves or others that are in there that are taking care of them. Safety. Well, if they're in an advanced stage, we worry about them wandering off outside of the facility, getting struck by cars, getting lost, falling, those sorts of things. And just as I said when I was talking about orthostatic hypotension, we want to advise them to get up slowly, sit on the side of the bed first for at least a few seconds, and then stand up to prevent that orthostatic hypotension where they'll possibly pass out. Monitor for any GI bleeding. Some of that goes with hepatic insufficiency, and inform the families and of local Alzheimer support groups. This is a very difficult disease for a family. There's a lot of conflict. They are conflicting emotions. Essentially, they see this person that they've loved and cared with and cared for, and who's cared for them their whole life, and then suddenly that person's gone. They're no longer who they were, especially in the advanced portions. It's a very difficult thing. So, case study. We have a client who has Parkinson's and is taking Sinemet. What laboratory values may be altered in a client who is taking levodopa, and compare the different actions of the drugs used to treat Parkinson's and to reduce their symptoms. Make sure you go over these drugs before the test. So, which comment to the nurse indicates more teaching is needed for a client taking levodopa? I know I need to take this drug once a day. I know I shouldn't stop taking this drug abruptly. I understand my urine may become dark and discolored. I know it may take a few weeks or months to control my symptoms. Answer is A. The statement from the client such as, I know I need to take this drug once a day, indicates that more teaching is needed because levodopa has a short half-life. It has to be taken at least 3 to 4 times per day. So when we're talking about the other answers, if you remember right, one of the things, we don't want to stop taking this suddenly because they can get a reflexive and increased symptoms. If they suddenly come off it, it can also cause hypertension and palpitations. We also know that by taking these drugs, the urine may become dark, discolored, sweat may even be discolored. And I know that it may take a few weeks or months to control my symptoms. It's obviously true as we're building up the ability for those dopamine receptors, both to receive dopamine and then to also increase the secretion of dopamine. Practice question number 2. Which side effect, adverse effect of levodopa does the nurse realize is most important to monitor? Dysphagia, increased libido, agranulocytosis, or urinary retention? Urinary retention is the big one that we need to look through and consider with those patients taking levodopa. All right, gang, on to chapter 24. That'll be on the next video that you should find on the YouTube channel.